Hello everyone and welcome to this video. So let's quickly recap. In the previous video, we saw all about tuberculous lymphadenitis, its overview, the mode of infection, the sites of infection, the most common site being the cervical lymph nodes. We saw about the mode of infection, and then we also saw in detail about the clinical features and all the stages of lymphadenitis. In this video, let's continue talking about the clinical manifestations, the diagnosis, and the treatment. So let's start right away. This includes the acute type, the caseating type, the atrophic type, and the hypoplastic type. Now in the acute type, as the name suggests, this is seen in infants and children below the age of 5 years, where the overlying skin appears red and edematous. Along with that, the child may have moderate fever, and the clinical pictures resembles that of acute septic lymphadenitis with signs of acute inflammation. The next is the caseating type, which is the most common one, and it is seen in young adults. Here the glands appear multiple, moderately enlarged, the main feature being matted together. The caseation leads to softening, formation of cold abscess, and progressively sinus formation. The patient may appear anemic and moderately nourished, and the constitutional symptoms such as fever, anorexia, and weight loss may be present. Now moving on from the infants and young adults to the elderly, the picture here is a bit different. Now, naturally, because the lymphoid tissue undergoes involution, the glands are comparatively small, and that is why with the onset of caseation, they burst very soon. Opposite of this happens in hypoplastic type, where there is a marked degree of reactive and lymphoid hyperplasia. Okay, so naturally this will be seen in people with good general resistance, where there will be more granulomatous tissue and less caseation and periodontitis. The glands appear to be notably enlarged, appear fleshy, elastic, freely mobile, resembling those in Hodgkin's disease. Okay, so with this we have completed the type of clinical manifestations, which included acute, caseating, atrophic, and hypoplastic type. And it is quite easy to correlate this with the age that it is seen in. In the diagnosis of TB lymphadenitis, apart from the clinical features of chronic lymphadenopathy and areas of matting and soft areas of caseation, the main tests include raised ESR, CRP, and low hemoglobin levels, and a positive tuberculin sensitivity test. These days, it is superseded by the interferon gamma release assay. As usual, the sputum is sent for culture and sensitivity, and the staining is done by Zeden-Nielsen method, where we detect the acid-fast bacilli, as you can see here. Specific investigations for lymphadenitis include aspiration of the pus in cold abscess, which is again sent for culture and sensitivity. And in early stages of adenitis, we can prefer excision biopsy. In most cases, positive FNAC and biopsy are essential for confirming diagnosis. And the gold standard here is a biopsy, the lymph node biopsy. Now, what does this reveal? Right, this is the picture of what we would see. At the top right, we notice the hallmark, which is the caseation necrosis, surrounded by epithelioid cells. So this is how the epithelioid cells appear. They're modified macrophages that resemble epithelium. Apart from that, we see multinucleated giant cells, as we see here, with up to 20 nuclei. There's also a lot of inflammatory 20 nuclei. This is the gold standard test. Apart from that, in the presence of a cold abscess, the aspiration will naturally reveal cheesy material because of caseation necrosis. And in sinus formation, we can go for an edge biopsy. Finally, now that we have completed the clinical manifestations and the diagnosis, we'll wind up by talking in brief about the treatment. The treatment mainly includes the multi-drug regimen, the aspiration, and surgical excision indicated. So starting with multi-drug regimen, this includes two phases. The first is the intensive phase and the second is the continuation phase. In the intensive phase, we aim to kill as many bacilli as possible and aim to make the person sputum negative. In the continuation phase, we aim at the persisters and the dormants. Okay, so this process includes 4 drugs, which are remembered by the mnemonic RIPE. It includes rifampicin, isoniazid, pyrazinamide, and ethambutol, where rifampicin and isoniazid are continued in the continuation phase. I've written the dosages here, which are 450 to 600 mg for rifampicin, 300 mg for isoniazid, 1000 to 500 mg for ethambutol, 1000 to 500 mg for ethambutol, and 1500 mg for pyrazinamide daily. This is calculated based on mg per kg body weight. Apart from that, in surgical approach, in the case of a cold abscess, we perform repeated non-dependent aspiration. Okay, so aspiration from the non-dependent area of the abscess with a wide pore needle along a Z-track. Okay, so a wide pore needle along a Z-track is used to prevent the formation of a sinus. Finally, surgical excision is indicated if the glands continue to persist after adequate chemotherapy. And in the case of a development of a sinus, excision of the sinus wall along with the sinus tract may be indicated. So with this, let's quickly recap what we've studied so far. We started with the types of the clinical manifestations, where we saw the acute, caseating, atrophic, and hyperplastic type. We moved on to the diagnosis, which included the clinical diagnosis, tests such as raised test for ESR, CRP, and hemoglobin, tuberculin sensitivity test, sputum for culture, Zeden Nielsen method staining for acid-fast bacilli, aspiration and excision biopsy, the gold standard being lymph node biopsy and positive FNAC. In the treatment, we saw the multi-drug regimen, aspiration and cold abscess, and surgical excision when indicated. So with this, we come to the end of the lecture. I hope it helped you in whatever way possible, and I hope to see you in another lecture soon. And if this helped you, make sure to like and subscribe. That would be really motivating. Thank you.